My name is Laura Kelsey. I'm the medical director for Michigan West, and I practice in Muskegon and Grand Rapids. Pelvic congestion syndrome is an achy, dull pain that women experience. Feels like you're having your period, even though you're not, is how I describe it. Typical symptoms would be bloating, abdominal pain. You could have low back pain, some irritable bowel sort of symptoms like constipation, alternating with diarrhea. The most common signs that are pretty paradigmatic for pelvic congestion syndrome is pain with intercourse and pain that can last after intercourse. It's very common in women that have had multiple pregnancies, and it can progressively get worse. So there's really two sources of pelvic congestion syndrome. The first source is the ovarian vein. So the ovaries are in the pelvis, obviously, and instead of draining into a local vein, they travel up, it's called the gonadal vein, and it drains into the kidney. And so there are little valves in there. So one of the causes of that is that ovarian vein can rupture, or those valves can break, not rupture, but those valves can break and creates pressure in that vein, and then that vein dilates out, and that pushes varicose veins into the pelvis. The second source of pelvic congestion can happen to men or women, and that is that an artery is sitting on a vein somewhere in the abdomen. So those are congestion. If you think about an artery, think of it like a big bully with a thick muscular wall where veins are really flimsy and easily compressed. And so the most common cause of compression is called May-Thurner syndrome, where the artery comes down and at the belly button it divides to give the iliac veins, or the iliac arteries. And so where it crosses over, it can compress that iliac vein. And that can lead to outflow pressure that builds up and can cause those varicose veins in the pelvis as well. Well, I think starting with your primary care doc is always a good idea because they have a good handle on the medical history. For women, we really worked simultaneously with the gynecologist because women have a lot of reasons for pelvic pain. They can have ovarian cysts, they can have endometriosis. And so partnering with your primary care doc to isolate what the possible causes are, and then a referral to us is always beneficial. When we see patients, we'll start with an ultrasound of the legs, actually. And what that will do is help to identify if there's any veins escaping from the pelvis, or we can also filter through the history and we can look at the deep vein and see if there's any pressure in that deep vein that would be reflective of some compression syndromes. First you start with your primary care or gynecologist, and they will do a physical exam and take a history. In addition to that, a transvaginal ultrasound can be ordered by the gynecologist that will look for veins crossing the midline in the pelvis. In addition, they can look for varicoses that are escaping into the labia or the vulva or into the perineal space, so upper inner thigh or in the gluteal folds. Also, they will exclude other sources. So the ultrasound is really helpful to them. Sometimes the gynecologist will move forward with a laparoscopy to look for endometriosis and other sorts of things. When they're referred to us, a lot of that workup has already been completed. And what we'll do is an ultrasound of the legs to, again, identify, is there reflux disease? Is there escape veins there? Is there deep vein disease? And then based on their history, physical, and the findings, we can refer forward for additional studies. There are ultrasounds that can be done of the pelvis to look for a dilated ovarian vein. There are also ultrasounds that can be done to look for compression of the iliac vein. Those require specialists that are trained specifically in doing that. More commonly, people will have a CT or an MRV, which is venous phase MRI, to kind of look for those things intra-abdominally. The nice thing about those studies is it'll also exclude other compressive sources like cancers, masses, lymph nodes, etc. Once those are done, then a venogram can be done. So it's a staged approach to this. A venogram would inject contrast into the vessels and it would watch the flow. And there's some diagnostic strategies to that. And the best study that can be done is intravascular ultrasound, where I think of IVUS as a colonoscopy for your veins, so to speak, where an ultrasound is actually pushed through the veins and it takes measurements of the diameter and it can look for obstruction in those veins. So I think as a woman, myself having children, you just accept some degree of pelvic pain as normal. And so a lot of women just don't have a place to go with that pain. It can be very progressive. Hormonal manipulation can be tried to see if dropping the progesterone and estrogen levels will help control the symptoms. But yeah, it can be terrible for women. I've had patients that really at the end of the day can't stand even to finish dinner and put the dishes away kind of thing. And I don't mean to make that stereotypically a woman's job, but as a mom, you're on your feet all day long, and these women are unable to complete all the tasks that they're asked to do in a day. Another thing that's very difficult for women is it's very painful to have intercourse. And so they start to not want to engage in that, which obviously leads to different problems in relationships and insecurities. I think the hardest thing that I see for women is when they have this pain. Pain isn't visible always, and because this goes underdiagnosed, I think women go to a lot of physicians without good answers and good options for treatment. And I think that also really hurts them psychologically to think, gosh, am I crazy? Am I making this up? Like, is there anything wrong with me? So it's good that pelvic congestion is getting some airtime, honestly, because I think this isn't a condition that just started. I think it's been around for a long time. I think we still see a lot of women getting a hysterectomy for pain. Of the women that get a hysterectomy for pain, up to 30% of them will still have pain, and it's assumed that this was really pelvic congestion syndrome, and a hysterectomy would not be the appropriate treatment for that. So diagnosing the source of the situation of the congestion is important. So if it's an isolated ovarian vein problem, ovarian vein embolization, where basically they stop the flow in that vein, that's not much different than what we do for varicose veins. We treat it like a varicose vein in the pelvis, where we close the flow to that vein, and that stops that pressure from flowing backwards. I see that done often for younger women and with quite a bit of relief. So if we're seeing a lot of labial varicosities and vulvar varicosities, that's a treatment option for them. Another option is if they have compression syndrome, right? So the artery is sitting on the vein. Maythorn nerve, for example, is most common. A stent can be deployed in that vein to actually create enough structure to lift that artery off and restore the flow through that vein. We have patency studies up to 30 years now, and so in the past, this wasn't a treatment that was readily available, which now it is. IVUS also helps us understand what degree of compression we're dealing with. So you certainly don't want to go to someone that's just going to put a stent in first, right? You want to have the diagnostic criteria met. And you certainly want to have excluded other sources of that pelvic pain, but there are readily available treatments for women. My heart goes out to these women, and I would say, a lot of insurances don't require that you have a referral to see a specialist, and your gynecologist might have done everything at their capacity and just aren't aware of who in your community is practicing and able to manage pelvic congestion syndrome. Worst case scenario, you go and someone tells you it's not that, but at least you've checked that box, and so any of us at Center for Vein Restoration are happy to filter these patients to see them, help with the diagnostics, and we partner with people within our communities to help treat this if that is in fact the cause. At the first visit, we still do an ultrasound of the legs, and sometimes that's confusing for women because they're coming in with pelvic pain. And again, the reason we look for the leg first is women can have symptoms that go down into their legs. That compression can be seen on ultrasound. in the form of deep vein reflux. They can have escape veins, they can have labial veins, varicosities that are, signs and symptoms of pelvic congestion. So that's the first step. And so by gathering that information and partnering that with their history and physical, we're able to have a more concrete approach and then move forward with additional studies if necessary. So it's a long appointment because that ultrasound takes about 45 minutes, and us gathering appropriate history and doing that education can take another 45. So it's about an hour and a half appointment.